Biofeedback is clearly an important discovery, and one which is likely going to continue to provide new insights for helping people take more responsibility for their own health.
I might say, well, do you know swimming? I may ask him, do you know typing? But I never ask him, do you know thinking? How to think is the quality of man.
What excites me is that we haven't exploited the intrinsic endogenous plasticity of the brain. We know about it from hypnosis, from psychosomatic disease, from laying on of the hands. There's something there in its physiology. It's not magic, and we haven't gotten to it yet. I think biofeedback offers a really good tool for getting that process under control and using it beneficially in medical treatment.
There are advantages in having a non-surgical, non-medication therapy. And if we prove by the work we're doing that it has therapeutic efficacy as an adjunct or by itself, that's fine. But just as the alpha high and the biofeedback literature went out through Life, Look, Playboy, Glamour, the Wall Street Journal, and so on, so this can be distorted equally, and it's bad news.
I think what we're trying to do in the film, essentially, is not to stimulate interest in the field, but to try to tell a story of where we stand right now. Probably we could tell this story in a great many ways, but one of the best ways I think that it might be portrayed is to just go to good laboratories or go to people who are doing some work in the clinical area and ask them to tell us what they're doing.
The roots of biofeedback are buried deep in human history, but to lay a foundation for our investigation, we first visited the more recent past.
I think I recognize that famous dog.
Yes, that's my dog Nick that we studied for 14 years in the laboratory from his time he was 1 year of age until his death at about 15 years old, and about which I wrote a book, Experimental Basis for Neurotic Behavior. Although I went to Russia intending to stay there only 4 months, I stretched my sojourn out to 7.5 years on account of meeting Pavlov and wanting to learn from him his ideas and techniques about the conditional reflex.
Traditionally, learning is classified into a number of different paradigms for the learning process. There are two well-known paradigms. One is called classical conditioning. This is a situation where a stimulus is made to occur in relation to a signal of some kind, and the subject learns to associate the signal with the stimulus and respond to the signal.
As you know, with the salivary gland, we give a signal, a bell, and then we give food, and then we see if the bell itself will cause a secretion of saliva. Now, in this experiment, we give a tone, which substitutes for the bell, and then we give the dog caffeine in a meatball. Now, the caffeine increases the secretion of the kidney, which is going on all the time. Then we want to see whether the dog can become conditioned to the meatball and the tone for the increased secretion of urine. As I understand it, the distinction being made was that in classical conditioning, the dog does not, you might say, voluntarily participate in what is going to happen.
Operant conditioning really was begun, or first termed perhaps, by Thorndike, who spoke of the law of effect, and this was picked up by Skinner, who developed the concept of operant conditioning, which implies that the individual or the subject operates upon the environment to bring about a reward.
When he used sporadic shock, which was not very often, he used what was not called now Pavlovian classical conditioning, but it would be called operant, because Pavlov had it arranged so that if the dog lifted his foot, he broke the circuit and avoided the shock.
In instrumental learning, or trial and error learning, or operant conditioning, whichever you want to call it, the reward strengthens any immediately preceding response.
He presses a lever or pecks a disc or does something in order to induce a change in the environment, and as a result of that, he gets a reward.
with a human subject who is trying to succeed, his knowledge that he is succeeding serves as the reward to cause him to learn that response.
A few of the demonstrations of how patients learned to use feedback, information, to control their disease is a man with retrocollis whose head was almost always this way, and on asking him how he watches TV, he says, "Well, Doc, I do this." And the information, this is not a restraint, a physical restraint, it's the information that allows him to know where his head is, that he can watch TV.
We think that today most of human learning really develops along the operant line, that is, people learning to manipulate the environment in such a way as to achieve their objectives. Biofeedback really is just a new wrinkle on this idea.
What we do in biofeedback is use instrumentation to measure what is happening to something like blood pressure, heart rate, skin temperature, and hence give the subject much more accurate information than he would ordinarily get.
It is any electronic methodology, and I suppose we should say electronic biofeedback when we are using electronic biofeedback, which gives instant replay to the subject of exactly what's going on inside him so that he can modify that response.
It really might be called instrumentally augmented feedback because we use instrumentation to augment it. The word bio comes in because it's of a biological process, so it's feedback instrumentally augmented of a biological process.
We found that the utilization of biofeedback with musculoskeletal responses is a very active area. Dr. John Basmajian was one of the early researchers in the use of electromyographic feedback. He recreated for us his experiment in single motor neuron firing, which did much to stimulate research in this field.
It's a very dramatic and easily demonstrable thing, and it really began in the early 1960s with our work. All right, Mr. Hudson, we have put these electrodes into one of your small muscles in your thumb, and we connect the subject up to the loudspeaker and the oscilloscope feedback, and then we show him the EMG tracings that he produces, and he hears the sound. And from the shaping of these biofeedback devices, he is led to activate single motor neurons, or motor units as we call them when we pick them up from the muscle, until you have only one unit going. There. No? Clean that up now. In biofeedback research, mainly it is to demonstrate the preciseness and the absolute controls that can be obtained over even this most minute particle. Getting there? Beautiful. Keep it going now. And when I ask you to turn it off, I'll count to 3 and I want you to bring it back again. Okay. Off. 1. We'll try it again. Bring it back. When I say off, turn it off, and I'll count to 3, and when I say 3, bring it back again. Off. 1, 2, 3. Beautiful. Now we know that its major impact seems to have been as an introduction to general biofeedback research and application.
As far as what gave the immediate impetus to our work was the work by Basmajian, who has demonstrated infinite precision of control of a single motor unit and impressed us very much with this, what he called external proprioception.
We think that there is a blockage of some sort, and that by training the patient, we can override that blockage through conscious effort. In other words, use of his cortex to activate, for example, the tibialis anterior muscle, which is not activated during the swing phase of walking.
After measuring the performance of his right unaffected lower extremity and establishing the level of such performance, we are switching the unit to his affected left extremity, and I am going to urge him to reach the same level by raising his foot up. Would you please raise his foot up? Higher. Stronger. Can you reach the level of the dot above? Should you reach it, Very well.
The clinic subjects are accepted only after a history of unsuccessful traditional treatments. It is emphasized that there must be some nerve pathways left which can be exploited through biofeedback training.
The patient teaches himself. He relearns. Dr. Brodny likes to use the word sensory motor integration. There's a new level.
Or he's establishing a new sensory motor relation.
By using surface electrodes to pick up and feed back the electrical output of the muscles, researchers like Dr. Herbert Johnson on the West Coast and the ICD group here in New York have obtained positive initial results with foot drop and torticollis. Biofeedback is also being used in highly preliminary work with other neurological disorders, such as cerebral palsy and certain injuries to the spinal cord.
We have very good indication that in some people, under certain conditions, it appears to be useful as a symptomatic treatment. We have to find out by careful studies, which will take a considerable amount of time and a considerable amount of money and a great deal of effort, exactly where the indications are, where the contraindications are, where the limitations are.
Firstly, the modern man needs more of peace of mind because he's in more of conflict. In order to have more peace of mind, he must meditate.
What does biofeedback buy you that you can't get with these older techniques? In fact, we use some of the older techniques and bits and pieces of them integrated with the biofeedback.
Biofeedback has the advantage that people can learn it quickly because they see what's going on.
It seems that biofeedback is Western man's way of getting to a cultivated low arousal point.
Well, what we're doing with biofeedback principally is using the biofeedback as a tool. And we're using it essentially as a tool to train deep relaxation and then specifically to train the asthma patients to relax in situations which had previously caused them anxiety.
We're finding that biofeedback can help us reduce the amounts of tension that are causing speech difficulty and stutterers far better than perhaps we can do it firsthand by clinical inference or observation.
Well, this stuff comes directly from up the street at the University of Colorado Medical Center, where Tom Baczynski and Johann Stoive are doing the work at the biofeedback laboratory there.
It's quite well known that people who suffer frequent or sustained stressful episodes eventually will show some sort of a physiological breakdown. Keep that tension held in that muscle group. Keep focused on it. Okay, now begin slowly to relax the tension.
Preliminary relaxation training is often given to prepare the subject for biofeedback training sessions. Training in the relaxation of the frontalis or forehead muscle has produced promising results in the treatment of tension headaches.
What biofeedback does is to take the individual from the nominal relaxed point down to a very low point. And of course it does this by making the individual exquisitely aware of the functioning of his muscle systems. So every so often, shift your attention to that tone and make sure that you're keeping it at a low level. And that will ensure that your forearm is relaxed as you begin this new training on your forehead muscle. Here we have the output of the forehead EMG integrator, and those are the clicks that you're hearing. Here is the output of the forearm EMG integrator rather, and the tone is recording the feedback from this particular channel. So the tone will track the forearm, the clicks are tracking the forehead right now. Typically, we will train this individual, the one with tension headache, to this criteria of 3.0 microvolts average for 20 minutes. And when he can do this, and when he can do it without feedback, he is generally ready to abort headaches or even prevent them from happening in real life.
The bowel work is a combination of fortuitous events. First, it was our own intuition that the GI system lends itself to this kind of work, and that there are many problems of the GI system which should be controllable. The other was the advantage or the fortune of having Dr. Schuster in residence. Dr. Schuster is an eminent gastrointestinal specialist whose major interest has been in motor control. And so it was a natural collaboration that's worked out nicely.
Patients with fecal incontinence generally have impaired external sphincter function, and it's our purpose in the biofeedback program to train them to develop good reflex contraction of the external anal sphincter in association with the normal reflex relaxation of the internal anal sphincter. The polyethylene catheters lead to pressure transducers which record pressures from these areas. The rectal balloon is used to initiate rectosphincteric reflexes by transient distension of this rectal balloon. The patient is lying in the right lateral recumbent position and is observing the recording as it comes out. This is the feedback which is provided to the patient concerning her rectosphincteric responses. By this technique, she can determine whether she's responding appropriately or inappropriately, and we can then reinforce the appropriate responses by making her aware that they are appropriate, and we can then help her to eliminate the inappropriate responses by making her aware that they are inappropriate. We've trained about a dozen patients and have had very excellent success in all but one. We've studied patients who've been incontinent for all of their lives because of a myelomeningocele, a tumor of the spine, which affects the nerve supply to the anosphincteric area. These patients have generally responded very dramatically and very rewardingly to biofeedback training. Our studies in the anorectal area using biofeedback techniques and those in the lower esophageal sphincter area using the same techniques lead us to some very promising conclusions. What is indicated here is that gastrointestinal function is accessible to control by biofeedback techniques, even those functions which have heretofore been thought to be totally involuntary.
Such things as blood pressure, heart rate, brain waves, these are functions of either the autonomic nervous system or highly complex functions of the central nervous system, and it hadn't been thought in the past that people could voluntarily alter them as they can, for instance, contract a bicep or a striate muscle.
Well, I think most of our work has been to see whether people can learn to control their blood pressure, and I think over a series of about 5 years or so we've come to the conclusion that there is a great potentiality that people can develop self-control of the blood pressure. Although we don't know yet to what extent we can get results that are of a reasonable magnitude to make them of physiological and clinical significance.
And this is a very big diagnostic category. Maybe 25 million of the population suffer from this disorder. We think it's unlikely that any one approach is going to help all of those people, but it may be that the feedback approach can help some of them. And who are they?
We've been able to teach monkeys to control their hearts, and we expect to be able to study the whole cardiovascular integration in that animal, and then to try to put that together with the human work.
The feedback to the monkey is the same as to human subjects. However, the reward is the avoidance of a mild electric shock. A red light tells the monkey to slow his heart. The yellow light warns him of impending shock. The entire experiment is under the control of a computer.
A well-trained monkey may not get a shock for several days, and if he does get a shock, you might almost guess that he's doing it to make sure that the system is still functional.
Some of you probably know Bernard Engel on the East Coast. He's been doing this with patients for about 4 years and has found that by means of biofeedback, people can learn to regulate even pieces of the heart.
Yeah, well, we've published, I think, 3 papers with different kinds of patients with cardiac arrhythmias, patients with premature ventricular contractions.
Dr. Tom Pickering in my laboratory has repeated some of these results, and here we see a young boy who, after training, has learned to control his PVCs. here at rest, the large spikes are the abnormal beats, alternating with small spikes, which are the normal beats, in a condition called bigeminy. When he's told to go into normal or sinus rhythm, you see he does at this point with the smaller spikes, and then recovers it here. On the next part of the record, which is continuous, he's told to go back to bigeminy, and he soon does completely. It is hard to imagine any placebo effect which would enable a person to have voluntary control so that he could turn the abnormal beats on and off on request. It's this voluntary control which makes the results by Engel, and which we are repeating, so convincing.
You feel that work is pretty well established now then?
Well, the laboratory demonstration is clear. The replication of particular observations in our experience has been quite clear. Now, to take what we've seen in the laboratory to the clinic is a big, big step. And certainly we haven't done that. That would be something for the future.
Now, if the individual has migraine headaches, branching from the frontalis EMG training, we would go to temperature feedback from the hand. This, as you know, is the technique which was pioneered by the people at the Menninger Foundation.
In 1964, when we came to the Menninger Foundation, one of the things we were most interested in was whether or not it was really true that people could learn to control the temperature of the hands, as was said in autogenic training books.
So I think Jacobson, a long time ago, had discovered that when a person relaxed his muscles and his hands got warm, that perhaps his migraines tended to diminish.
Here you can see that the change in temperature is indeed produced by a change in blood flow, as one might expect it. This is a measure of the blood flow in the digital artery. It goes up and down with the pulse. At this point, the subject is told to cool his hands. He is an exceptionally talented subject who has already been trained, and you see his blood flow drops immediately and his pulse is greatly reduced. The temperature comes down after a lag. Then when he's told to relax, the blood flow almost immediately returns to normal and the temperature gradually goes up.
Migraine is a different kind of animal that is concerned mainly with blood vessels that simply expand too much in your head, and it's that vasodilatation of these extracranial blood vessels that causes the pain of the migraine.
Generally, the patients start out with autogenic type phrases, at least in our training program.
Now, after I've read several of the phrases, I will interrupt you and ask you to open your eyes. And then I will turn the feedback trainer around, and when I do, please utilize this information, this biofeedback information, to facilitate further relaxation. My whole body feels heavy, relaxed, and comfortable. Warmth is flowing into my hands. They are relaxed and warm.
After a while,
my thoughts are...
sometimes right away, the patient will drop the phrases and instead will substitute something else. And we found that patients like to generate their own techniques for warming up the hands. And of course, the important thing about this is that, and with a biofeedback machine right in front of you, you can tell instantly whether it's working or not.
The best explanation which exists at this moment is that the increase in blood flow into the hands, into the periphery, is caused by a decrease of sympathetic activation. In other words, you're making your autonomic system go just the opposite to what it generally goes when you have a migraine headache.
When we examined graphs, I felt that the graphs showed that about 70% were getting benefit. Dale Walters felt that maybe 80% were getting benefits. Dr. Sargent, who was actually working with the patients, felt that maybe it was 90%. Well, we compromised on 80%. But it all depends on how you measure it.
It has been said by people who study headaches that they are flagrantly susceptible to placebo effects, and that somewhere between 60 and 70% transitory cures can be produced by placebo effects.
Of course, we know that there are two kinds of placebo effects. One is when the patient thinks he's getting better and next week he dies or or let's put it mildly, he gets sicker. But the other kind is the one where he feels that he's getting better, and actually he is getting better. And the reason for this seems to be that whatever you visualize, if it's picked up by the unconscious, has a tendency to appear in the body.
I think the results on the headache research are encouraging enough so that it certainly is worthwhile doing further clinical tests, but I think it's a long ways from announcing that we have a definite cure.
The control of the temperature of the hands suggests the capability of the mind to bring about certain physiological changes without intervention of the skeletal muscles.
This rat is paralyzed by curare, a drug that prevents the movement of the skeletal muscles, such as the arms and legs, but leaves the autonomic nervous system relatively unaffected. Since he is paralyzed, he has to be artificially respirated. His eyes are covered because he can't blink, and we want to prevent them from drying out, which would make him uncomfortable. He is trained in an avoidance learning procedure in which a tone comes on, and if his heart rate changes in the correct direction, he turns off the tone. If he doesn't do this, the tone remains on until he receives an electric shock. Thus, the tone provides the feedback of the biological function of heart rate, and the electric shock provides the motivation for the learning. One of the most extreme experiments was the one in which we rewarded rats for a difference in the blood flow between the two ears, and we indeed got a difference. So it is this kind of specificity that we have come to believe rules out mediation via the skeletal muscles. On the other hand, what has happened is a very puzzling thing. This learning, for some very mysterious reason, declined over the years. We're now trying to find out what went wrong and how we can get it back. If we do this, we think this may produce a fundamental increase in our knowledge of the conditions necessary to produce successful visceral learning.
Dr. Miller's laboratories are also conducting a number of studies of visceral learning using human subjects. In this experiment, a subject is successfully trained to produce a temperature difference between each hand. This demonstration of specificity is considered evidence of the absence of mediation by the skeletal muscles. At this time, we also had a chance to see examples of the variety of feedback devices available to the subject and the experimenter.
Tell us about the ways you know you're succeeding.
Well, it's very easy to know, and it's an immediate knowledge too. You can first concentrate on the needle, and if the needle goes towards the appropriate direction, you know immediately that you're doing the right thing. Also, the Nixie-tube display moves accordingly, so you know exactly in digits how much the difference of the hand has changed. Also, very pleasing is the display on the lower side where you get the money. That also tells you immediately how well you are doing. So those three visual things tell you immediately. Also the sound. The sound will go towards one ear or the other, go up or down in pitch accordingly to the temperature differences. So there is a lot that you get, and you can even choose one or the other depending on which one you feel more comfortable to.
In the biofeedback process, the training process, the biological information is in the form of a symbol. It's a man-made artificial symbol of what is going on in the body.
And the request of the patient is, if he has a paralyzed arm, is not to move his arm. So if the pace of the biceps, we say, okay, look at these dial readings, hear these clicks. When those clicks go higher, that means your muscle is contracting. So never mind the muscle, make the clicks get higher.
He has an entire, complex, sophisticated mechanism by which he can unravel the meanings of an abstract symbol of his inner state and devise the internal means to control that internal state.
I notice if I get myself in a very relaxed, if I get relax, and let my mind wander a little bit, the lights seem to work more rapidly.
It's like a little hum almost, and it sounds like I experience it as. And I try to concentrate on staying in that type of, with that sensation, and that seems to set off the lights.
You can't describe how you raise your hand. You just want to do it and do it. It's much like that. Some subjects use the imagery, some use other things, but well, it hasn't helped us so far very much to get their verbal reports.
Up to now, we've been dealing with biofeedback techniques applied to muscles and viscera. A substantial segment of biofeedback research involves the spectrum of electrical frequencies emanating from the brain.
In line, and they tried to stop, and they just couldn't.
Yeah. Well, I just hope it doesn't get worse.
I say about 8 inches, so I don't know.
Dr. Thomas Mulholland is one of the early researchers in alpha biofeedback.
I heard reports of...
Alpha frequencies occur between 8 to 12 cycles per second.
Stay here all night.
I don't think I'd like...
The main idea in brainwave training is to give Esther information about her own brain rhythms. To do this, we have to pick up the brain rhythms, we have to amplify them, and then use those amplified brain rhythms to control complicated electronic devices which will permit us to have a sound come on when alpha rhythms are occurring. Esther, that's great. You're producing lots of alpha rhythm. Now I want you to start to train yourself to produce even more alpha rhythm. I'm going to give you something which is more rewarding as a clue to when your alpha rhythm is coming on. And we're going to use the music that you selected yesterday. And the music will come on when your alpha rhythm comes on, okay?
So I should increase the alpha.
Increase the alpha.
Okay.
People who produce lots of alpha don't necessarily have grand insights, tremendous psychic experiences, or anything like that. Generally speaking, if you're producing lots of alpha, you're fairly calm, not paying attention to the environment, you're not engaged in lots of purposeful movements, your emotional level is probably low, and certainly you're not going to sleep. And I think that last part is rather important because a lot of the meditative exercises for the novice are designed to help him avoid sleep. Alpha goes away when you go to sleep.
Dr. Mulholland uses computer-generated information obtained from biofeedback sessions to develop new techniques for research and diagnosis of mental diseases. Use of the appearance and disappearance of alpha to operate an on-off switch has lent itself to a variety of applications. Dr. Mulholland has been working with increasing the attention span of students, also with the possibility of developing computerized teaching machines which can detect lagging attention and change the input accordingly. In Dr. Barbara Brown's laboratory, a subject demonstrated the control of a toy train. This device was developed for the alpha biofeedback training of children. Dr. Brown also demonstrated her experiments with rapport training.
There are some lovely studies which have demonstrated that, say, between a psychiatrist and a patient, over many interview sessions, their biological responses tend to become almost identical. Why should we not try to use biofeedback to accelerate the development of this process? In our experiments, all that we did was to give them a signal which indicated when both people of the pair had alpha activity present in their EEG patterns almost simultaneously. and we give them a little leeway, and then we make it harder for them and make it have to appear almost simultaneously in order to get a feedback signal.
If a person has sleep onset insomnia, we have found that it's not just enough to train them to relax their muscle systems. This will help in some cases, but not all. And so what we do as a second phase of training is to give them theta EEG training. This is the 4 to 7 cycle per second rhythm, which is characteristic of a drowsy kind of stage of wakefulness bordering on sleep.
We noticed in some of our research studies in our lab that when people were producing the brain rhythm known as theta, that quite often they would have hypnagogic imagery that just comes suddenly into the mind from some unconscious source. Also from my study of creativity, I knew that many creative ideas have come suddenly into the mind, the solution of a problem, when people were in a state similar to what people are in when they're producing theta. Kekulé called this a state of reverie. And so we started a study with 26 college students, which went on for 10 weeks, training in increasing their percentage of theta, the time, that is, that they could stay in the state of consciousness that would give them the feedback tone that would say, yes, you are in theta, you are in the right state. In order to do the things we are asking students to do, one must keep a certain level of awareness, but at the same time, it's as if one were stepping back from the situation, stepping back from what your mind is doing and being the observer, so that it is allowing something that you are not thinking about to come into the mind.
It helps my reason rather than dealing with my emotionalism, you know, and when I do that, then it's somehow
patients who go through theta training procedures find that they are learning things about themselves that were buried in the unconscious.
I'm getting pretty relaxed.
Are you seeing any images?
Yes.
Can you describe these to me?
The theta state is characterized by images in different senses, which are felt to be important to the person. That is, the unconscious brings these up to the conscious mind, and if the person can work with those, he can integrate those into his conscious self and therefore grow or mature. And the Greens have seen this happen with students at a university.
Through the feedback, now I can recognize what level of consciousness that is, and I can sit down with or without these wires and machinery and recognize a theta state.
At the nearby Veterans Administration Hospital, the Menninger Clinic theta training techniques are being applied in a research treatment program for alcoholism and other chemical dependence disorders. A major effort of this program is to rebuild the subject's much-needed self-confidence.
Biofeedback teaches them that they can control that inner process, which has always been said to be autonomic or automatic or involuntary.
As they can see their own progress, little by little, they begin to have a feeling, I can change, I can control my destiny to some extent.
The average patient goes into a doctor, he turns his body and his mind over and says, fix me, I'm broken. Biofeedback says you can't do that. You have to take responsibility and get into it yourself.
Once they see that you're going to begin to give their primary symptom attention, they'll often, by what they think are asides, give you a lot of reasons why they have developed this way of dealing with their tension.
The biofeedback can be a tool to insight. You have to ask them, well, what was your experience like on the machine? Say, well, it was funny, you know, his mother-in-law, who I love so much, I thought about her and the clicks went up.
The sensory motor rhythm is different from the alpha rhythm in that it arises from a different part of the brain, the sensory motor cortex. The alpha rhythm appears in the occipital cortex primarily. It's a different frequency. It's 12 to 16 cycles per second rather than the 8 to 12 cycles that makes up the alpha rhythm. And it's associated with an entirely different subjective state. We know that when subjects do produce the sensory motor rhythm, they tend to suppress the alpha rhythm, and we're finding more and more evidence to suggest that they're quite different states, and somewhat mutually exclusive.
Inside of the box we have a cat who has been trained to produce sensory motor rhythm for a reward of electric stimulation of the hypothalamus.
And it dawned on us when we were working with these cat experiments where we were actually producing some rather profound changes. For instance, a cat who had been given this EEG biofeedback training for an extensive period of time was suddenly resistant to seizures. And it wasn't as if he was turning on a conditioned response in the old sense, which we know can block epileptic manifestations.
Kevin?
Yeah?
Today we're going to fly the airplane and the rocket, just like we did before, okay?
Okay.
Can you make the rocket go up?
Yeah.
All right, let's get you hooked up and we'll do that.
We have been personally criticized because we don't do control studies. We haven't brought in enough patients who are epileptics and tried other things like theta and alpha on them. We invest 2 years in a patient. I mean, if we sign a patient into our study, they're going to come in 3 times a week for 2 years. Our feeling was, in order to cope with this, that the first thing we wanted to do is find out if the model we were working with had any validity at all.
Okay, Captain, this is the tower. You ready for takeoff?
All right, we got to get the rocket off the ground. Here we go. The point is that we are giving him, through the feedback, an opportunity to focus on a brain state, which he seems to enjoy. And by doing that, we seem to be countering the seizure process.
I have to speak personally now in terms of my own experience. I got together with Dr. Brodney, 71, to do this type of work that we're doing now. Prior to that, we were working with alpha feedback and seizures. Now, we had some very dramatic results. 2 patients, 3 patients. And, you know, but it just was not enough, and I was not convinced, and I was more convinced the lantern was better for seizures than feedback. Now, I'm not saying that feedback can't be used for seizures.
You're saying that at the present time, you're in no way trying to convey the impression that you have discovered a new method to treat epilepsy, which is now universal, to be applied.
Agreed. I will say that we are very hopeful that we have found an alternative to chemotherapy and all of its negative side effects in the treatment of epilepsy.
And the question comes up quite often from physicians as to whether or not we're ready for clinical applications. It's an interesting question, and it is not going to be answered, and the reason is because a lot of doctors, as soon as they find out about biofeedback, begin using it in the clinical situation. So at the same time that we're doing research, they're doing clinical activity.
Well, I think there are areas that are open to what the general practitioner might be able to do if he has just a little bit of reasonable guidance. For example, I think some of the muscle feedback devices are not too bad. And since there's a long history of material with progressive relaxation, autogenic training, and so on, I think that's an area he can tackle fairly successfully.
To the extent that biofeedback is used by a clinician to help achieve that, that's great. But I think it's premature for practicing physicians to attempt to use this to treat in a routine manner high blood pressure, for instance, or epilepsy, as the work we're doing, other kinds of diseases, because I think we just need more time with it.
If an unscrupulous person is trying to sell equipment or sell the treatment, he might be getting money from somebody for something that may not be doing him any good, or it might distract the person from getting a proper diagnosis and the kind of treatment he needs. But say compared with drugs which have side effects, these are types of treatments are very mild and harmless.
With an average person who doesn't have a physiological problem, it probably isn't harmful. But a lot of the people who are using biofeedback and want to use biofeedback have problems.
With a patient referred to our group with a definite question of a brain tumor the other day.
Yeah.
I mean, with a hemiplegia.
Yeah, you have to be very careful.
And we're very excited about what we found. But we also find that if the equipment that one uses is inadequate, or if the wrong frequencies are being reinforced, that in the case of the epileptic, you can actually reinforce paroxysmal activities and then exacerbate the condition.
My fear is that some of the exaggerated claims in the public press will lead to unrealistic hopes which will produce inevitable disillusionment, and that this disillusionment will interfere with the opportunity to do the work that is necessary to see how far man can learn to extend the voluntary control over his visceral organs and over functions that hitherto have been thought uncontrollable.
Now, my work has shown where that limit is, and I think that limit is with those organs where it would be extremely injurious and upsetting to the balance of the body economy, that is a disturbance of homeostasis.
I don't know what the limits are. I think that we can make some possible guesses based on normal homeostasis, and in many respects they may be correct. But on the other hand, there are lots of things that we thought were impossible which we're now finding to be possible.
There's a difference between exploring and being cast adrift, and I think that in a new field like this, we really can't tell when it's going to impose a limit on us.
I have always been a visionary, and sometimes have been severely criticized for that because it has given rise on occasion. I suppose I've contributed to the general view that biofeedback is going to save mankind. Nothing of the sort will happen. Mankind will only be able to save itself. I hope that we will be able to help it save itself, however, by the use of properly placed probes which will help individuals come more directly in contact with what's happening inside their bodies.
I have a feeling that many of the investigators today will have dropped by the wayside in EEG biofeedback. In the electrocardiographic and blood pressure control types of work, here obviously we have a practical application if it can be extended to the clinical level.
In the clinical area, it will be integrated into the general field of medicine. It will help, I hope, to break down the barriers that exist between the behavioral sciences, including psychiatry on the one side, and medicine on the other. It's a rational behavioral approach to medicine, and I anticipate that it will become a strong therapeutic technique in the future.
We could not present everything that we saw or heard. For that matter, we certainly did not visit all the researchers that were doing significant work. But if we attempted to sum up in a few words our feelings and the feelings of all who work in biofeedback, we would go along with Dr. Miller, who told us,
in this new area, I believe we should be very bold in what we try, but very cautious in what we claim.